So thank you for the opportunity to speak a little bit about work we've been doing at the Durham VA, and I wanted to first acknowledge the team that we have, which is a really wonderful interdisciplinary team of physicians. We have representation from psychology, from chaplaincy, geriatrics, biostatistics, and our analytic groups of qualitative analysts and others. And so it's been a great pleasure to be able to work across disciplines on this kind of project. As is in palliative care, it's so essential to really think about all of our assessments and approaches in a very multidisciplinary kind of way. So I thought what I would do is tell you a little bit about, just give you some context about part of what motivated this study. Some of this came out, of course, of work that we have done for years looking at what's important to patients and families in the context of very serious illness. And we know that, of course, spirituality and religion are central, and attending to that kind of aspect of their personhood is essential to comprehensive care. And when I say spirituality, I mean it in the broadest sense possible, which has to do with how people seek and express meaning and purpose in their lives, and may connect with what we think of as quote unquote the sacred, if that language works for them. For many, that's expressed through religion, and for others through strong relationships, through a sense of nature, through a relationship with a transcendent more broadly. But if we look to the literature, as we see on this slide, about what we know about the importance of spirituality in healthcare, I want to just highlight a few things. That when we look at samples of seriously ill older adults, we see ranges from the upper 60% to upper 80% in terms of people who identify this as being an important aspect of their care. When we look into very acute health situations, which is often when it is studied, we see that between again, very high percentages in the 70s and 80% identify as having spiritual needs. And when we say spiritual needs, we mean that, again, in a broad sense of issues of grief or despair or suffering related to unresolved conflict or broken relationships, for example. And even when we look among those who consider themselves to be agnostic or atheist, within those groups, still about 2/3 in some studies have shown that they still report a spiritual need, with over 40% of that group reporting more than 4 spiritual needs. So this is kind of a very cross-cutting issue, important for most of our patients and family members. We also know that it's really spiritual coping is central to general coping at this time, and that what we think of as negative coping, which has to do with having belief systems that assign a sense of punishment or a sense of blame to the self, are really strongly associated with poor outcomes like poor quality of life, as well as depression and anxiety. In larger studies, particularly the Coping with Cancer study, we see that satisfaction and quality of life are higher across populations when spiritual needs are attended to, and we know, interestingly, that costs are lower when spiritual care is attended to. We believe the mechanism may be related to helping identify preferences and values and being able to align those with treatment preferences. We know that beliefs are central to decision-making and treatment choices. So the question is that while we know that all of this is important, and we have spiritual assessment mandates, both from in the palliative care world, a recent consensus conference, again, identified spiritual needs as central to one of the 8 factors that we should be addressing in care. Also, the VA Directive 1111 talks about that every veteran should receive a spiritual assessment, and it gives you some of the information that should be gathered. And yet, the problem is that we really lack a gold standard for making these kinds of assessments. And such an assessment would help to both facilitate internal as well as external accountability of that care, and also we hope that such an assessment would help to define what interventions should be administered, as well as facilitate communication among members of the team about addressing spiritual care needs. So in short, we know that it is a significant part or aspect of patients' lives, and yet our science has not caught up to being able to assess that in a consistent and standardized way. So if we were thinking about what is it that we would be hoping for, we'd want a tool that is, and I'm just listing on the side what you all know about assessment, something that's quantifiable, valid, useful, efficient, and inclusive. And on the right-hand side, I have some information about what that would mean in the context of spiritual care, so that we would really be able to identify degrees of distress, potentially be able to note changes in that over time, be able to have a tool that is acceptable both to the patient as well as to chaplains who are going to be receiving this information, and also that gathers information that feels useful and actionable to the rest of the team. So as an aside, in other project we're doing, when we looked at how often, we did this actually on the Duke side of my research, where we looked at all the number of times that chaplain notes had been opened by providers across the health system. And we're able to do that with performance services, and found that the percentages were, astonishingly low. And then when we go and we ask our colleagues, tell me about why you are not reading this, because we know that chaplains sit at the bedside and get really crucial information that patients and families are willing to share with them that affect their treatment. And frequently the clinicians will say, I don't understand the notes, and I don't understand what I should do with it. And usually they're about, this is a little bit of a straw person argument, but they can be 12 paragraphs long. It's this very thick narrative. And so how can we find something that would be in a different format that is more actionable? And what I've already alluded to is that when we think about assessing patients in this realm, we have really kind of a tension around our assessment approach. On the left-hand side, I'm having this be a picture related to chaplain tradition, which is they're trained in a more narrative assessment, having patients tell their story, and then from that glean information and then relate it. And it's related in what's called a verbatim, which is the chaplain goes and word for word describes what happened in the interaction. That, as you would know, is in sharp contrast to the way that physicians and nurses communicate their preferences for care, which are bulleted, which are really empirically data-driven, and bulleted short form. So in creating this approach to assessment, we felt that we needed to honor both of those and try to figure out a way to at least hold that tension and see where that guided us. So what we did is we have a grant from HSR&D for a 3-aim study where we look at first developing the content of the assessment, and that is a largely qualitative approach. Then after analyzing all those data and creating an initial draft of an assessment, we cognitively tested it among patients, and then within that second aim, also validate it quantitatively in larger samples, which I'll talk about. And then finally, as all those data are complete in the last part of the study, we will be developing a toolkit for use with providers and different groups of providers. So it's really a multi-method, patient-centered approach. So to give you a little bit of background on the qualitative data, and that's what I'm going to describe today, are really the tool itself and how we think it responds, the structure of it responds to what I've talked about in terms of needs. So we had focus groups and individual interviews with the groups you see here. We did individual interviews with patients and families so that they are very ill. Bereaved family members were easier to get to be in touch with by phone. It's more convenient for them to speak by phone, and then we can get a lot more depth of data, whereas our providers, it was more convenient for us to meet with them largely in groups, although sometimes individually if that was needed. And then, as I mentioned, what we did is we took all of those data. We had 3 coders who worked with the data, created matrices examining differences across groups, looking at themes of both the content that was important as well as the processes of care that different groups valued, how they wanted the tool to be designed. And then, like I said, we did cognitive interviews. And the patients we worked with were those who had advanced illness, either a very advanced cancer, usually a stage 4 cancer or 3B lung cancer, COPD, congestive heart failure, and stage renal disease. So within clinics within the VA. When we looked at what were some of the data that we received in terms of what was important in terms of process, you can see I've put side by side findings from the chaplains and the medical team. So chaplains were very much highlighted that it needed to be a patient-centered approach, non-judgmental with inclusive language, that it had a sense of empowerment, so not just be a problem-solving approach, or a problem-identifying approach, but an opportunity to express strengths as well. And they again spoke about the importance of narrative. The medical team wanted information that was actionable, that helped them understand how beliefs affect treatment, to know how to support the patient and family, and as they said, what they want me to know. That was what let me know what the family wants me to know, let me know what the chaplains want me to know. So a very different kind of style. When we talked about to the chaplains in a little bit more depth, one of the things that they were challenged by was that they said, I understand that I have to give an assessment that's more standardized, or that needs to be given to our patients, and yet I often have one point of contact with any given veteran. And I don't want that point of contact to be assessment. I want it to be care. I want it to be, and some would say in their language, I want it to be ministry. I want it to be an interactive point. And so if I'm filling out a questionnaire, that doesn't feel good to me, and we're not going to use it. So they were open to the idea and like the idea of a pre-encounter kind of inventory that would gather information ahead of time. And so we started looking at that format, which was very different than what we originally thought, that was going to be a tool that was in the hands of the chaplains at the point of care. We also heard some interesting things. We have a lot of data, but just a few of the things that were unique we thought to the veteran experience was that while in the tradition of thinking about spiritual care, when you read about that more broadly, people talk about spiritual injury. Within the veteran population, we have really high populations of people who've experienced moral injury, who have been ordered to do things that were against their own code of ethics. And so we needed to address that in the instrument and be able to assess that can be a part of experience. We also heard the importance of strength that veterans talked about. When you're in the military, you get taught to be strong. I wish that our providers knew that we could tap into that and help us use our strength in our own care. Prayer seemed to be really important across groups, whether they were considered themselves religious or not. Again, growth was important. Most of our veterans have had experiences with many different people across the country and within their ranks, and so we're very highlighted the importance of being able to have an instrument that spoke to their brothers and sisters in arms who may have very different beliefs. And again, wanted information for the medical team. So just quickly, here is the structure that we came up with. We have a series of questions that relate to, on the left-hand side at the top, that really will respond to the medical team, that get at importance of spirituality, impact on decisions, affiliations, use of illness. And then we have a section that feeds both the medical team, but really the chaplaincy team in terms of these subdomains: joy, strength, peace, vulnerability, forgiveness, moral and spiritual struggle, reconciliation, etc. And the way this works is these are the essential elements that need to be a part of the 1111 chaplain assessment. And as you would note, I could map these onto the framework before, so we actually, those questions in the instrument actually feed into giving the chaplain information about these issues ahead of the actual time with the patient, so they know what is crucial and what they might want to focus in on. So our next steps are the full validation that we're in the midst of right now, 250 participants, as well as comparison measures so we can do a full psychometric comparison. And then, as I mentioned, we'll go on with the toolkit for use. So I thank you so much for your time and happy to, at the end of this, answer any questions that you might have. Sure. Veteran.
Instead of calling, because that could create a conflict wall.
Thank you.
Even though bureaucracy may know all that, but yet, veteran, in my mind, I'd rather be called a veteran than patient.
Most of us, I think that's a great point of view. It's not an empowered word, is it? Yeah, thank you. Yeah, thank you.
Thank you, Dr. Steinhauser.